This video will go over acute respiratory failure and acute respiratory distress syndrome from chapter 32. Acute respiratory failure starts on page 624 of chapter 32. So when you think of respiratory failure, what do you think of? Right? There's some sort of problem with the body obtaining oxygen. Your textbook breaks it down into two different problems. There could either be a problem with airflow, a ventilatory failure, where the oxygen isn't flowing in and carbon dioxide isn't flowing out. So there could be a ventilatory failure or an airflow problem. Or there could be an oxygenation or gas exchange failure, which is a problem with perfusion being decreased. So the oxygenation, the air is coming into the lungs, but at the site of the alveolar level where blood is running by, for some reason the oxygen can't cross over into the blood, the carbon dioxide can't cross over into the alveoli. So with oxygenation or gas exchange failure, air moves in and out of the lungs without difficulty, but it does not oxygenate the pulmonary blood sufficiently. Acute respiratory failure could also be a combination of both ventilatory and oxygenation failure. It is classified by abnormal blood gas values, which are a partial pressure arterial oxygen less than 60, or a partial pressure of arterial carbon dioxide more than 45, and arterial oxygen saturation of less than 90% in both cases. The slide there says a PaCO2 of greater than 50 with a pH of less than 7.35. Your textbook, though, we're going to go along with your textbook, a PaCO2 more than 45 with a pH less than 7.35. Whatever the underlying problem is, the patient in acute respiratory failure is always hypoxemic with low arterial blood oxygen levels. Again, with ventilatory failure, blood flow or perfusion is normal, but air movement or ventilation is inadequate. It occurs when the chest pressure does not change enough to permit air movement into and out of the lungs. As a result, too little oxygen reaches the alveoli and carbon dioxide is retained. Perfusion is wasted in this area, so the blood's traveling past, but there's no air movement from either inadequate oxygen intake or excessive carbon dioxide retention, leading to poor gas exchange and hypoxemia. Ventilatory failure usually results from any of these problems: a physical problem of the lungs or chest wall, a defect in the respiratory control center in the brain, so a CNS type problem, or poor function of respiratory muscles, especially the diaphragm. The problem is defined as PaCO2 level above 45, and again the pH less than 7.35 in a patient who has otherwise healthy lungs. If you look at table 32-2, you have common causes of ventilatory failure. You have extra and intrapulmonary causes listed there. In oxygenation or gas exchange failure, there's air movement and oxygen intake ventilation that is normal, but lung blood flow or perfusion is decreased. Problems include impaired diffusion of oxygen at the alveolar level, right to left shunting of blood in the pulmonary vessels, ventilatory perfusion mismatching, breathing air with a low oxygen level, and abnormal hemoglobin that fails to bind to oxygen. In one type of ventilatory perfusion mismatch, areas of the lungs still have perfusion, but gas exchange does not occur, which leads to hypoxemia. An extreme example of ventilatory perfusion mismatch is when systemic venous blood, oxygen poor, passes through the lungs without being oxygenated and is shunted to the left side of the heart and into systemic arterial circulation. When poor oxygenation in the lungs or a shunt that allows venous blood to bypass the lungs occurs, even more arterial blood is not oxygenated, and applying 100% oxygen does not create the problem. A classic cause of such a ventilatory perfusion mismatch is acute respiratory distress syndrome, or ARDS. Table 32-3 lists some common causes for oxygenation failure. Combined ventilatory and oxygenation failure involves hypoventilation, poor respiratory movements. Let me see here. A combination of ventilatory failure and oxygenation failure occurs in patients who have abnormal lungs, such as those with chronic bronchitis, emphysema, or cystic fibrosis, or who are having asthma attacks. The bronchioles and alveoli are diseased, and the work of breathing increases until the respiratory muscles cannot function effectively, causing ventilatory failure, leading to acute respiratory failure. Acute respiratory failure can also occur in patients who have cardiac failure along with ventilatory failure, and is made worse because the cardiac system cannot adapt to the hypoxia by increasing the cardiac output. Now we'll talk about assessment of the patient with acute respiratory failure. The symptoms of acute respiratory failure are related to the systemic effects of hypoxia, hypercapnia, and acidosis. Assess for dyspnea, which is the hallmark of respiratory failure. The patient may also complain of orthopnea, finding it easier to breathe in an upright position. Assess for changes in the patient's respiratory rate or pattern and changes in lung sounds. Pulse ox may show decreased oxygen saturation, but end-tidal CO2 monitoring may be more valuable for monitoring the patient with acute respiratory failure. If his or her pulse ox may show adequate oxygen saturation, but because of increased end-tidal CO2, the patient may be close to respiratory failure. ABG studies are reviewed to most accurately identify the degree of hypoxia and hypercarbia. Other symptoms of hypoxic respiratory failure include restlessness, irritability, agitation, confusion, and tachycardia. Symptoms of hypercapnic failure may include decreased level of consciousness, headache, drowsiness, lethargy, and seizures. The effects of acidosis may lead to decreased level of consciousness, drowsiness, confusion, hypotension, bradycardia, and weak peripheral pulses. In terms of interventions, oxygen therapy is appropriate for any patient with acute hypoxemia. It is used in acute respiratory failure to keep the arterial oxygen level above 60 millimeters of mercury while treating the cause of the respiratory failure. If oxygen therapy does not maintain acceptable PaO2 levels, indicating adequate gas exchange, mechanical ventilation may be needed. Drugs can be given systemically or by nebulizer or by meter dose inhaler to dilate the bronchioles and decrease inflammation to promote gas exchange. Corticosteroids may be used. Analgesics may also be used. Now we're going to discuss acute respiratory distress syndrome, also known as ARDS, also known as wet lung. So if you think of that, if you can associate those two, ARDS and wet lung, it'll help you remember the pathophysiology of it. Acute respiratory distress syndrome, or ARDS, is acute respiratory failure with these features. Hypoxemia that persists even when 100% oxygen is given, also known as refractory hypoxemia. That's the cardinal feature. Decreased pulmonary compliance, dyspnea, non-cardiac associated bilateral pulmonary edema, and dense pulmonary infiltrates on X-ray with a ground glass appearance. Often ARDS occurs after an acute lung injury, and common causes of acute lung injuries are provided on Table 32-4 on page 626. It can occur in people who have no pulmonary disease as a result of other conditions such as sepsis, burns, pancreatitis, trauma, and transfusions. Despite the different causes of acute lung injury and ARDS, the trigger is a systemic inflammatory response. As a result, ARDS symptoms are similar regardless of the cause. The main site of injury in the lung is the alveolar capillary membrane, which normally is permeable only to small molecules. It can be injured during sepsis, pulmonary embolism, shock, aspiration, or inhalation injury. When injured, the membrane becomes more permeable to large molecules, which allows debris, protein, and fluid into the alveoli. The lung tissue normally remains relatively dry, but in patients with ARDS, lung fluid increases and contains more proteins. Surfactant activity is reduced in ARDS because type 2 pneumonocytes are damaged, and because the surfactant is diluted by excess lung fluids. As a result, the alveoli become unstable and tend to collapse unless they are filled with fluid. The fluid-filled and collapsed alveoli cannot participate in gas exchange. Edema then forms around the terminal airways, which are compressed and closed and can be destroyed. Lung volume and compliance are further reduced. As fluid leaks into more lung areas, fluid, protein, and blood cells collect in the alveoli and in the spaces between the alveoli. Poorly inflated alveoli receive blood but cannot oxygenate it, increasing the shunt. Hypoxemia and ventilation perfusion mismatch can result. Transfusion-related acute lung injury is the sudden onset within 6 hours of transfusion of hypoxemic lung disease along with infiltrates on X-ray without cardiac problems. Transfusion-related acute lung injury is associated with the activation of the inflammatory response caused by recent transfusion of plasma containing blood products. Acute lung injury can occur and can lead to ARDS, can occur by direct injury to the lung tissue or other causes. Direct injury to lung tissue can occur through things such as aspiration of acidic gastric contents, pneumonia, drowning, or inhaling toxic fumes. Indirect lung injury can occur due to sepsis, pancreatitis, trauma, or other conditions when inflammatory mediators spread to the lungs, causing damage. Your next slide gives a nice little diagram about how ARDS can lead to respiratory failure, so go ahead and review that on your own. Under health promotion and maintenance, the nursing priority and the prevention of ARDS is early recognition of patients at high risk for the syndrome. We want to watch closely those at greatest risk, including those who receive tube feedings, those who have impaired swallowing or impaired gag reflexes. We want to follow meticulous infection control guidelines, including hand washing, invasive catheter and wound care, and contact precautions. Under assessment and noticing, assess the breathing of any patient at increased risk for ARDS. Determine whether increased work of breathing is present as indicated by increased rate of respiration, adventitious lung sounds, cyanosis, pallor, retractions. Document sweating, respiratory effort, or any changes in mental status. Special note here, abnormal lung sounds are not heard on auscultation because the edema occurs first in the interstitial spaces and not in the airway. Assess vital signs at least hourly for hypotension, tachycardia, and dysrhythmias. Many patients with ARDS have altered core body temperatures on admission. Those with a temperature elevation early in the course of ARDS appear to have a better outcome with lower mortality than those who have hypothermia. In terms of diagnosis, we're going to monitor the patient's ABGs and monitor the partial pressure of arterial oxygen. The patient has a progressive need for higher levels of oxygen. He or she develops refractory hypoxemia and often needs intubation and mechanical ventilations. Sputum cultures obtained by bronchoscopy or transtracheal aspiration are used to determine if a lung infection is also present. The chest x-ray may show diffuse haziness or a white out ground glass appearance of the lung. An ECG rules out cardiac problems and usually shows no specific changes. We'll continue with management for ARDS in a different recorded lecture.